Appendicular mass. The appendix is inflamed, swollen, with all inflammatory exudates over its surface. The inflammatory exudates contain a lot of fibrin. Fibrin is nothing but a glue. This glue adheres the bowels and it adheres the momentum. So ultimately a mass is formed. So this mass is nothing but swollen edematous appendix with adherent loops of terminal ileum wrapped in edematous great momentum. And in this mass there will be fluid that is nothing but inflammatory exudates. Sometimes there may be a collection of pus in this mass. Then it becomes appendicular abscess. All these structures that are there in this mass are edematous. That means ileal loops and cecum, appendix, everything is edematous. And everything is adherent to one another. It occurs usually 48 hours after the onset of acute appendicitis. It won't occur in the first or second day. That is why if a patient comes to with acute appendicitis, within 48 hours, you can always do appendectomy. If it is after 48 hours, then you have to just think about whether a mass has formed or not. If the mass is there, then you can go for conservative management. Then you can ask me. In acute appendicitis, you told me that you cannot predict the course of the appendix. It may rupture, it may cause general peritonitis. Can the same thing happen to appendicular mass? Yes or no? When appendicular mass can perforate and cause general peritonitis or not? Yes, it is localized. There is wrapped up momentum and adherent bowels all around the inflamed appendix. That is why, even though it perforates within the mass. And the pus form within the mass. There will not be the fear of spreading peritonitis. That is why you can go ahead with conservative management. It is due to host resistance to contain the infection locally. The whole mass gets well circumscribed by 4th or 5th day. This mass increases up to 10th day and subsides usually by 3rd week. The mass increases in size after 10 days if an abscess has formed. So this is the progress of appendicular mass. If anything is deviated from this, you have to suspect some other disease, like ileocecal tuberculosis or carcinoma of the colon. Clinical features are classical features of acute appendicitis followed by a painful lump in the right iliac fossa. Sometimes the mass may not be palpable due to overlaying guarding of the abdominal wall. But by 3rd day or 4th day, the inflammation subsides and you will be able to feel the mass. General features of inflammation, namely pyrexia, melissia, and tachycardia are present. Differential diagnosis, ileocecal tuberculosis, carcinoma of the cecum. You must differentiate this from these two conditions. In the olden days, there used to be a condition called ameboma or amoebic granuloma of the cecum, Crohn's disease, external iliac lymphadenitis, investigations, blood counts, urine examination, stool examination for occult blood to rule out the cecal condition, radiological investigations, namely ultrasound scan, bear a meal after resolution of the acute stage colonoscopy. Ultrasound scan will reveal the mass as well as the abscess. If the mass is not resolving within 3 weeks, you have to do colonoscopy to exclude ileocecal tuberculosis and carcinoma. Management. It is due to the protective host response the mass has formed and the inflammation is localized. Your aim should be to help the body to contain the inflammation and to identify when the inflammation spreads to the peritoneal cavity and to deal with by surgery. For example, just now I said that appendicular mass is treated by non-operative measures, by conservative measures. So a medical colleague, that means a physician, will come and say, because this is non-operative, so I will manage the appendicular lump case. Will you permit it or not? Why? This is only medical management. You give antibiotics, you give IV fluids, nothing by mouth, painkillers, that's all. The inflammation subsides, the appendicular abscess mass resolves. The appendicular mass should not be treated by a physician. It should be treated by a surgeon, not in the medical ward. Again, it is often said that the appendicular lump case should be treated at the doorstep of operation theatre, not in surgical ward. What does it mean? At any moment, this fellow is thrown to the theatre. So what is that moment when you throw this fellow into the theatre? Whenever there is sign of spreading infection. So essential step in the management of appendicular lump is not just giving antibiotics and then IV fluids. The essential step in the management of appendicular lump is to monitor for the symptoms and signs of spread of infection. When do you say the infection is spreading? What will the symptom? The pain spreads. From right iliac fossa, it goes to the hypogastrium, left iliac fossa, umbilical region, left lumbar region, like that it spreads. When you examine, the tenderness also spreads. It is not confined to the right iliac fossa. The tenderness will be there in other adjacent quadrants. If there is spreading peritonitis, the patient will have paralytic ileus. That means distension of abdomen. Vomiting, the fellow starts vomiting bilious fluid or intestinal juices. Distension, constipation. So they suggest paralytic ileus. And general signs, whenever inflammation is spreading in the body, wherever it is, be it in the leg or foot or head or in the abdomen cavity, whenever inflammation is spreading, the most important and sensitive indicator for spreading inflammation is rising pulse rate. Today it is 1 or 2 per minute. Tomorrow when you examine, it is 115 or 116 or 120. So that is a rising pulse. A rising pulse is one of the most sensitive indicators of spreading inflammation in the body. That is in general. That also applies to the appendicular mass. And temperature also rises. So in the essential step in the management of appendicular lump is to monitor for the symptoms and signs of peritoneal dissemination. When there is peritoneal dissemination, you don't keep fights. Now you open the abdomen and deal with the appendix. Okay, with your conservative management, the mass has resolved, the pain has subsided. Then what do you advise to the patient? you must advise the patient to undergo appendectomy after about a period of 3 to 4 weeks. Why? The disease is completely waned away. Why do you want to do appendectomy for this patient again? It has been observed by statistical evidence that about 93% of these cases, they will get appendicitis again within 1 year. To prevent acute appendicitis in these patients, you do appendectomy. So you are performing appendectomy not immediately. You are performing appendectomy after an interval of few weeks. That is why this particular appendectomy is called as interval appendectomy. So one of the frequently asked questions in the examination, theory examination, interval appendectomy. So to manage the infected appendix after the resolution of the mass. So the procedure is by conservative management. This is called Ochsner-Sherren's regimen. Again, it is an important question in the theory examination. As surgery entails risk of damaging the inflamed and friable bowel in the vicinity and spreads the infection to the general peritoneal cavity. The Ochsner-Sherren regimen, it is rest to the bowel by nasogastric aspiration, nothing by mouth till peristalsis resumes and pain subsides, usually for 1 or 2 days. IV fluids and liquid thereafter. Enema or purgatives are avoided. Antibiotics, broad spectrum with metronidazole. Analgesics and sedatives for 2 to 3 days. Monitor for the signs of spreading infection, pyrexia and tachycardia. A rising pulse rate is the sensitive or the earliest sign of spreading peritonitis. Vomiting. Pain becomes severe and diffuse. Persistence of or spreading of the guarding or tenderness. Increase in size of the mass indicates abscess or diagnosis is incorrect. Once the lump resolves, appendectomy is done after an interval of 6 weeks. This procedure is called interval appendectomy. Contraindication for this regime. In children, you don't go for this particular regime because the greater momentum is not well developed. The chance of spreading inflammation and general peritonitis is very high. That's why even the person comes 3 or 4 days later, you always go for appendectomy. In old people, as the incidence of gangrene and perforation is high due to atherosclerotic changes in the vessel walls, you don't go for this regime. And in immunocompromised patients, or when you cannot find or feel a mass, or when the diagnosis is in doubt. So these are the conditions where you go for surgical intervention, not for the Ochsner-Sherren's regime.